All right, my name is Patrick Heyman. I am a professor at Palm Beach Atlantic University School of Nursing, and we're talking about isolated systolic hypertension. So definition, anytime you have systolic blood pressure above 140 and diastolic pressure below 80, that's considered isolated systolic hypertension. It's most common in the elderly, and we're going to talk about why. And as pulse pressure becomes greater as the patient ages. So as the person gets older, that gap is going to get bigger and bigger. So the reason for that change is because of actual changes in the arterial tree. Our aorta and our carotid and a little bit of our iliac arteries are very elastic in nature. And so they are able to stretch so that as the heart pumps, the heart doesn't actually have to pump all of the blood throughout the entire arterial tree. All it has to do is pump the blood that's immediately in the aorta and a little bit in the carotid. And so as those arteries stretch, it makes it easier on the heart. So your heart doesn't have to work as hard, and that keeps your systolic pressure down. What you guys probably learned in school was mean arterial pressure equals cardiac output times total peripheral resistance. How many of you remember that? You forgot it like 5 times, right? Okay. It really only explains mean arterial pressure. It does not explain isolated systolic hypertension. But the reason why patients get isolated systolic hypertension is that as you get older, you start to lose those elastic fibers in the aorta. So this little slide shows some of the differences between the aortic waveform and then progressing down through the carotid, the brachial, and eventually the radial. And what you'll notice is that as you get fewer and fewer elastic fibers, the systolic pressure goes higher and higher. And that's basically what we see in elderly folks who really have lost most of their elastic fibers in the aorta. And that's what I just said. So the way that it actually does that is by 2 things. One, as you have fewer of those elastic fibers, the heart has to work harder, and that's going to push blood faster. That's called increased pulse wave velocity. Got it. Okay. Now, when you push a pulse wave out from the heart, how many of you have ever played with water in the bathtub or a pool? You make a little wave. What happens when the wave hits the end? It comes back. Well, as the wave hits down towards the capillaries and it begins to come reflected back, ordinarily that wave is relatively slow and it's going to come back when your aortic valve is closed. What that's going to do is it's going to raise diastolic pressure, and it's actually going to increase the perfusion of the heart. So coronary arteries can only perfuse the heart when the heart's relaxed. Look at your hand for a second. I have a nice pink hand. I have that family heritage. Like, squeeze it. What happens to this color? It turns all white, and then it comes back to pink again. The reason why, every time your heart compresses, it's actually squeezing all of the blood out of the perforating coronary arteries. So your heart is literally running on empty every time it's contracted. When you have that increased pulse wave velocity, that pulse wave reflects back during systole, so the aortic valve is still open. So your heart has to pump even harder. So it's pumping not only against the original blood that was there, the entire arterial tree, now it's pumping against its own reflected wave. And so over time, you're going to have that increase in pressure. That's known as augmentation pressure. So when it comes to treating isolated systolic pressure, hypertension, there's 2 strategies. One is target pulse wave velocity. The other is target augmentation pressure. As it turns out, we have no good way to do this. So, the thing to remember is, when you treat a patient with isolated systolic hypertension, when you lower their blood pressure, typically their diastolic pressure lowers even more than their systolic. Once you get a patient lower than 50, they can't perfuse their heart. And so you can have a patient who's at risk for ischemia even when they have normal blood pressure, they have absolutely no lesions whatsoever, they still can't perfuse their heart adequately because their heart isn't relaxed enough for enough time with enough pressure to fill. So the most important take home is when you treat a patient with isolated systolic hypertension, don't over-treat them. And the new JNC 8 guidelines actually reflect that when they said, hey, for your elderly patients, it might be okay to give them a slightly easier goal. Now, that was an extremely controversial statement, but this is the reason why they said it. Now, when it comes to the drugs, the number one best thing that you can use is nitric oxide donors. Unfortunately, organic nitric oxide donors are notoriously bad at treating blood pressure. And part of the reason why is that we adapt to them very quickly, and that's called tachyphylaxis, or tolerance. And so if you treat a patient with isosylarbide, dinitrate, those sorts of things, what's going to happen for blood pressure, what you're going to find is that it doesn't really work very long. So if we can overcome that particular challenge in the future, that's probably going to be the best bet. But for short term, that's the best we can do. Now, a recent review of literature shows these different drugs have been tested with some success in some patients. So the take home is, when you're trying to treat isolated systolic hypertension, the very first thing is you really do want to start low and go slow. You want to individualize therapy. Some of these drugs work for some patients, but not for others. So you really do have to be a little bit of a detective. You've got to work with the patient. They have to be willing to work with you. And don't be afraid to actually try something a little bit different. As long as you're, number one, not letting that diastolic go below really 70. It shouldn't go below 70, but absolute 50 would be the lowest. There are some proposed new things coming up on the horizon. You might want to try these again. They certainly shouldn't hurt anyone. They're nutritional supplements. But they might be able to help certain patients. So, final take home. Particularly dangerous if diastolic pressure goes low. So don't treat the patient too low. I think I've said that 4 times, so it might be important. Individualized therapy. And then in the future thoughts, someday we might be able to actually reduce arterial stiffening earlier in life, and that'll prevent the development of this disease overall. I've left you with a number of references that you can read on your own if you're interested. And if you're interested in the Bible of arterial blood flow, it is McDonald's Blood Flow and Arteries. It is a book far smarter than I am. Thank you very much.